Namaste and welcome to Youth and Development, produced by today's Youth Asia. In the TV show Youth and Development, we bring young leaders face to face with the key players of development works.
We've been working now for a few days discussing issues of health in the community, discussing issues about community and about health and how the two are interchangeable or at least interface with one another. And yesterday we had a very inspiring and informative visit to Braun and Melamtsi, visiting one of the Dulical Hospital outreach centers as well as the government PHCC. We had the opportunity to meet some of the members of the community, the microfinance group, members of the outreach center as well as the government service. And what I'd like to discuss over the next few moments is perhaps the role of youth in this process of community-oriented health and community-oriented primary care. Many of the issues that we've been discussing in terms of health challenges, problems, illnesses have related to youth. One aspect that we have not touched on as much is the issue of youth as agents of change, and youth being part of the solution in addressing some of the health problems that we became familiar with yesterday and that we've been discussing in your own communities over the last few days. And I'd like to open for discussion how you view the youth of the community as partners in an activity that we hope to engage in and initiate that will improve the health of the community. So, some of you are medical physicians, some of you are community health workers, students, NGO representatives. We have a broad range of views and perspectives here in the room, and we have members of the Dulical Hospital staff with us today, as well as our distinguished guests. So no doubt that there will be a lively discussion. So I open the floor up to any comments, questions, suggestions.
In this context, most of the youths are willing to go abroad for study or work. Or even if they don't go abroad, they are willing to stay on the urban area of Nepal. In this scenario, how can we increase the number of youth participants on community-oriented primary care?
Thank you for that question. This is an issue that we have been discussing both informally amongst ourselves and to some extent also formally. In the communities that we visited, we found in the government hospital or the PHCC a severe understaffing of trained personnel as well as lesser trained personnel. We know the problem of bringing doctors into the rural area is not only native to Nepal, it's a global problem. Young physicians, young graduates of medical school who have spent much of their money and other people's money getting through medical school are more interested in more prestigious jobs, perhaps inside the urban setting, inside the hospitals. And the question of getting the trained personnel out into the rural areas is a great challenge. In this hospital, I understand that a financial incentive is provided for young physicians to go out into the community. I'm not sure that that is a solution that is viable and available in all settings. And we were discussing this morning, how can we address the training at the bachelor level the master level, and in the medical college, so that the idea of community orientation is not just something we pay lip service to, but it's something that we internalize from the upper echelons of the universities down to the individual lecturers and most importantly to the students. So I'm not sure that we have a universal solution that can be applied throughout. There's no doubt that the problem of Nepalese health personnel going abroad is a serious problem to the future of the healthcare system in this country. I heard yesterday or 2 days ago an estimate of between 40 to 80% of some batches of medical graduates going abroad. That is a tremendous burden on the community, on Nepal, and the efforts that go into training for years these people, who then take their diploma and head off elsewhere, leaves the Nepalese situation at a great deficit. Perhaps Dr. Ram or other members of our audience can provide some input and insight into how we might get youth. And when we use the word youth, it's a pretty liberal definition, because somebody graduating even at bachelor level probably would not consider themselves youth. But I think that at some level we're all youth. We're all learning. We're all experiencing new things. So how do we address the problem? How do we keep the trained people here in Nepal, and especially in the rural areas, in the underserved areas of Nepal?
What is the mechanism of primary health care in Israel? What is the success of community-oriented primary care in Israel, so that it could be applied in our context, in our country, for the improvement of the health?
Thank you for that question. We'll get back to the previous question then in a moment, as you have provided with some time to think about the Nepalese health care resources in terms of personnel. The setup of primary care in Israel is provided through a network of family health centers. These were originally started as stations, well-baby state clinics that were called and are called till today Tipat Chalav, a drop of milk. And the idea being that the health of the baby starts with nutrition, with breastfeeding, with access to clean, to sterile milk and so on and so forth, back in the days when this was not a guaranteed situation. Today, there is a network of these clinics that are spread out throughout the country. We have an extremely high rate of participation amongst mothers for antenatal checkups, as well as postnatal care, including very high immunization rates, home visits when necessary, and keeping to the schedule of antenatal and postnatal care visits. Alongside this government-sponsored and run network, we also have private physicians and private clinics that are offering similar services. And to some extent, certain segments of the population will prefer to go, as in Nepal and as elsewhere, will prefer to go to the private care setting as opposed to the public Tipat Chalav centers, the well-baby clinics. And this has created a great deal of discussion in Israel in recent years as to how to continue providing services, including school services. The school services in Israel are also sponsored and regulated by the government. However, a number of years ago, 2-3 years ago, the government decided to privatize these services in the school settings. The result was, the experience was not a huge success. We found that when the services were in the hands of the private sector, they did not perform quite as well as when they were under a broader national program. And there's discussions today about how to rectify and how to correct that situation so that we can maintain the high level of health care amongst our babies, our infants, as well as our mothers, expecting mothers, and birth mothers. Primary care for adults and adolescents is provided through a system of 4 health care insurers. Everybody in Israel, every resident of Israel, is entitled to a basket of services, similar to the Nepalese system of medication services that is provided virtually free of charge, or certainly at a very discounted rate, through clinics that are operated through these 4 major HMO-type organizations. And these interface with the hospital setting. The major HMO, the major insurer, also runs its own hospitals, and the government runs also a network of hospitals. The government running a network of its own hospitals creates a very important challenge for us, because the government is also the regulator, also the watchman, and also the provider of care. And we're constantly discussing these issues of how the government can also regulate and also provide care at the same time. The continuity of care from the infant stage, or even the antenatal stage, through curative services to tertiary, secondary, and tertiary hospital care is quite good in terms of the continuity of care. But again, there's challenges, just like in any system, in ensuring this continuity of care. As far as COPC, the community-oriented primary care model within Israel, in Jerusalem, as we had mentioned, the Hadassah Medical Organization, together with the Hebrew University School of Public Health, ran a clinic, a family health care clinic, and a well baby clinic under the model of COPC for several decades, in which it provided the health care within the context of an academic setting that allowed the health care needs of the population that were identified by health surveys and other activities of data collection to be addressed through interventions that were developed specifically for the community that was the catchment area for this particular clinic. This is a very expensive and large operation for a single clinic. It was a multidisciplinary team of physicians, nurses, social workers, epidemiologists, demographers, statisticians, and so on. And we had the academic backing of the School of Public Health. Through this clinic, we were able, as I said, to identify the health needs of the community and develop interventions that were specific for this particular community and the characteristics of the community. In the 1950s and 60s, this was an immigrant population with rather low education, a mix of cultures and languages that presented a tremendous set of challenges to the healthcare team. And what came out of this was a major program on early childhood stimulation, and parents, mothers, fathers, to interact with their children at a very young age, because this was not the cultural norm. And yet the evidence from the literature, from clinical work, from epidemiological, we know that early stimulation brings about greater success in terms of better indicators in terms of growth and development. The other area of focus was coronary heart disease amongst the older adults, and an entire program was set up. These 2 programs became the basis of spin-off programs. They were evaluated on a regular basis as I said, for many years. However, about 10 years ago, the hospital came to the conclusion that as a tertiary care hospital, it can no longer afford to run this kind of setup. And this clinic was closed as a COPC clinic, and it became a regular HMO-run clinic, which may or may not today be running with a community orientation. Elements of the COPC cycle, which we've been discussing over the last few days, have been integrated into many of the systems that operate within Israel under the framework of the 4 major healthcare providers, as well as the well baby clinics. So there are communities throughout Israel that are being served by the different providers that have a community orientation. Many of the professionals within the healthcare system in Israel, the district health officers, virtually all the district health officers in Israel, and district health nurses, chief nurses, are graduates of our School of Public Health with an orientation of community medicine and COPC. So it's kind of a natural expression in the way that services are developed. I can't tell you that that the services are following the exact cycle with all the bells and whistles and crossing all the T's and dotting all the I's exactly as we've been talking about it. But one of the things we've been mentioning greatly throughout the workshop is the need to adapt models. There is no such thing as taking a model off of the shelf and saying, we are going to apply it here. Even if it's a Nepalese model that's been used in Kathmandu, it may not be appropriate for a community 50 kilometers away. And again, this is the advantage and the main principle of the community-oriented primary care approach, is that we look at each community and the community characteristics individually. COPC as a model has been taken throughout the world. In Catalonia, Spain, in the UK, in the United States, there are departments or schools of public health that have COPC tracks, that have diplomas in COPC-oriented public health. Our team from Israel has been to numerous places, including Turkey and South Africa and Macedonia. So we've been taking the COPC model, which originated in rural South Africa in the 1940s and 50s. We took it back to South Africa to train healthcare professionals in this approach, as well as I mentioned in other countries in Eastern Europe, Western Europe, North America, and South America. Every time we approach a community, the COPC picture, the model looks a little different. The challenges are different, the characteristics of the community, the resources available are different. And one of the main underpinnings of the COPC model is to utilize the resources that are in the community. So whether these are women who belong to a microfinance group, these are youth who go to youth clubs and can become agents of change, whether these are temples or churches, whether these are schools, NGOs, or natural resources. That's the idea of the approach. To look at the community, look at the available resources, examine the healthcare services that exist, and see what can be done further to address the specific needs of this community.
The youth may have the specific type of rights. So, but when they go to the health center, maybe we have seen yesterday also, in one clinic, they have to express their feelings in the one room where there are so much independents are also there, women and also waiting people are also there. So how can we improve on that? Even though there are so many kinds of strategies are there, policies are there, but we are not implementing. I think so. Many of the health centers. I think in COPC we have to address all those kinds of concerns with the youth as well. But I would like to ask Dr. Neumark, how do you see from that? What kind of things should we improve on those concerns?
I'd like to take this opportunity in response to this question to introduce Ms. Vinita Sharma. Vinita just completed her Master's of Public Health at the Braun School of Public Health and Community Medicine in Jerusalem, Israel, last week. And as a resident of Kathmandu, I was very pleased when Vinita agreed to my invitation and request that she join me in facilitating this workshop.
That was a brilliant question, ma'am. There is no question that, yes, adolescent health is very neglected in terms of implementation in our country. There are beautiful plans and policies in favor. However, when it comes to implementation, be it public health posts, primary health care center, or even tertiary hospitals, the existence of youth-friendly health services is very minimal. So, I agree that we are lacking. But what do? We have to take the first step. And as you mentioned, the way we could make a little bit of change, bring a little bit of improvement, is by including youth participation in the prioritization process. Not just prioritization process. I would say, let's start off with the community definition and characterization itself. Let's bring in youth people, youth representatives into this entire process of planning health interventions for the community. They have their own issues. And it's not necessary that health issues are already highlighted in the records that we have, because again, the records do not specifically indicate adolescent health problems. So if we include adolescents right from the beginning of this COPC cycle, I'm sure that the list that we have of top 5 diseases or top 10 diseases, there'll be a dramatic change in that. We'll have a lot of issues regarding sexual health, reproductive health issues of adolescents. So that is one way we could do it. However, we need to be careful. When we say youth representatives, we have to make sure that these are actually youth representatives and not just the name. So I would say, being a youth myself, I would say meaningful participation, meaningful representation of young people in each and every step, right from planning, organizing, implementation and evaluation of any health program and any health project, is the only way we could secure a youth-friendly, healthy Nepal for our future.
We discussed over the last few days issues specific to young people. We talked about mental health issues. We talked about early pregnancy issues and the difficulty and the challenge of working or addressing health concerns that have a deep root in tradition and in culture and in religion. And as public health professionals and as clinical medicine professionals, addressing these issues in a way that we believe would lead to a healthier society. Lower the burden of illness and mortality amongst young adults that are related to these issues, but do it in a way that is culturally sensitive, that is acceptable to the youth. And as has been mentioned, having the youth participate in the planning and the implementation of the interventions throughout. We were youth, maybe we still are youth, but today's youth is a little different. Today's youth may be a little more or a little less attached to traditions. Certainly today's youth are more accessible on mobile telecommunication facilities, and the idea of using mobile phones to get health messages to the youth is something that should be discussed. This is an area that is of increasing interest of my own. I am now spending a great deal of my time, my research time, looking at the use of internet and mobile telecommunication technology for health interventions for youth, specifically in the area of alcohol and drugs and smoking, but we can be discussing the same technology with regard to sexual activity or what other issues that are affecting the youth and the youth feel that they would like more information and help in seeking care. So this is one avenue that can be explored because many people have access to mobile telecommunication, to mobile phones. And it's a technological challenge to do so, but it's not insurmountable. So this perhaps is a direction that we can think about going, as well as opening up more dialogue with youth inside the community. So where we have groups of women coming together and empowering the women through microfinancing and so on, we can establish groups of youth to become the youth leaders, and then spread the word further and train the trainers, and so to speak, have the youth, as we said, become agents of change towards a better health.
With this, we have come to the end of today's show. We look forward for your feedback. Our email address is youth@tya@gmail.com. Thank you for watching us. We hope to see you next week at the same time. Have a nice week. Namaste.